Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
They don't know because they have to get exactly. That's amazing, yeah.
You just sort of feel.
So there's not like gardening. Yeah.
I'm like, don't worry, it's not
All right, we're going to try to get things assembled. Our GEC meeting kind of ran a little over, so we'll try to get things going here with Dr. Young. So first of all, just a preliminary happy holidays to everybody. We will be off for the next 2 weeks, next week being Christmas, the following week being New Year's. The following week will be a department grand rounds, and then on January 15th, we'll have our dress rehearsals for the American Academic Circle Congress, which will be in Orlando in February. Other housekeeping announcements, just thanks to all the residents for your involvement with the interview process. Yeah. So the residents personally who I interviewed, I would always lead with, did you get to go out last night? Did you get to meet the residents? And they were overwhelmingly positive. They were amazed at how many people showed up, how helpful y'all were in telling them the hopefully real stories, maybe not all real stories, but the real life day-to-day things that kind of help them navigate this. And then even on their written feedback about the whole interview process, that was still one of the highest ranked things. So everyone appreciates your involvement with that and keep it up in future years.
This is a really big deal.
Yes.
I'm so glad you're saying something, Dr.
Thanks, Dr. White.
I thought this, I mean, this is a very big deal. I would say it's a differentiating thing.
So keep it up. All right, so for our speaker this morning, it's my pleasure to introduce Dr. Felix Young. He was born and raised in Lima, Peru, and then moved to Los Angeles at the age of 15. Like everyone else who lives in LA, you just go to USC for undergrad, right? I mean, anybody can do that. And then decided to transfer to the American Heartland at the University of Illinois in Peoria. And then following medical school, he then relocated here where he is continuing in his residency, and then following completion of his residency, he is planning on moving back to Los Angeles for a trauma acute care fellowship at Cedars-Sinai. So we look forward to hearing about informed consent.
Thank you everybody for having me here. I remember when I was interviewing actually, and that day, Dr. Kelly Hewitt was talking about nutrition. My thoughts was like, oh my gosh, this is going to be extremely scary. Unfortunately, it's going to be a long time away. But it's not. This 5 years have gone by real fast, and I'm really happy to be going to be presenting about this topic. Now, the reason why I chose informed consent is because not too long ago I was actually on call, youth call, with one of my colleagues. That day we had a very complicated case on a lady who seemed to be healthy, seemed to be comfortable, but unfortunately needed an emergent procedure. Now, the process of informed consent that day was particularly hard because she had no awareness on how sick she was and how this procedure can really be a life or death type of situation for her. After getting the informed consent and after discussing at length with her and her family, this resident, Lauren, and I started talking a little bit more about the process. We really have a lot of education in terms of providing informed consent, yet this is the trust of a patient's and doctor's relationship. And I wanted to dig a little bit deep in terms of what it means to provide informed consent, how is it that we do it, if there's any models out there, and how can we improve. Because in my future career, I'm going to be dealing a lot with sick patients, with emergency procedures, and discussions that are not going to be easy. With that said, I have no disclosures to make. And my talk is really going to be concentrated on what is informed consent. There's going to be a little bit more in the dry part of the talk because I need to define informed consent, I'm going to give you a little history of how it actually came about, then some of the models of informed consent. And the meat of my talk, though, I decided to concentrate about within this vast topic is, are we doing a good job? Particularly as residents and as doctors. And then, how can we improve? So, for a patient, informed consent may actually look like this, which is really not great. But defining informed consent. Now, if you look at a dictionary, informed consent can be said as permission granted in knowledge and possible consequences of said procedure. But in layman's terms, what it really is just an ethical contract and a medical legal document that bounds us to that patient. But if you dig a little bit deeper, it's really not just this ethical medical legal document. It's actually a contract that arises from mutual trust and is built within the patient-doctor relationship. So, where did this all start? Actually, in this case, in 1914, was the very first time that the term simple consent was actually established. This case, Schollendorf versus Society of New York, is really the prime example of informed consent. Ms. Schollendorf suffered from uterine fibroids, and she had discussed with the surgeon about this operation and exactly what is it that needed to be done. She had only consented for an exploratory laparotomy, but the surgeon decided that it was in her best interest to actually remove the fibroids. That did not fly well, unfortunately ended up in litigation. This judge, Benjamin Cardoso, is coined as defining this term simple consent, which really changed medical ethics forever. This is actually him in the front cover of Time magazine in 1940s. And it's Dr. Nelson Gears. They put all this history just for him. But he said, every human being of adult years and sound mind has the right to determine what shall be done to his body. And a surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damages. Except in the cases of emergency, where the patient is unconscious, when it's necessary to operate, consent can't be obtained. Now, as the law continued to progress in the 1950s to 1970s, so did informed consent. Now, the root of the cause and what they actually started to trying to investigate were these two questions. Did the physician provide the patient with adequate amount of information? And on the basis of this information, did the patient provide consent? The other landmark case that I want to discuss about is this one in 1972. This Canterbury versus Benson. Mr. Canterbury underwent laminectomy. But unfortunately, he ended up paralyzed after the case. The physician had not even talked to him about the risks. It just says, you need a laminectomy, this is what we need to do right now. So that litigation actually ended up in this thought about we need to move towards a reasonable patient model. And I'm going to talk a little bit more about that in the future. But this reasonable patient model basically defined the importance of respecting the autonomy of the patient, and kind of was the one ruling that where shared decision making was born. Before that, what I had been practicing is this reasonable physician model, which is a more paternalistic model of viewing and doing informed consent, which I'm going to talk about just now. That revolutionized this model of informed consent and our discussions with the patients. Now, in 1975 on, there are a lot more states that said, now this needs to be a legal document. And 25 states, just within that year, enacted an informed consent law. Now, really quickly, let's talk about the definition of informed consent. First one, we need to have, for this to be a legal document, we need to have adequate information about diagnosis, surgical, non-surgical management, benefits, and risk. But it's not just the information that we provide. It's also assessing the understanding of that the patient is understanding what we're actually talking to them about. Finally, it's allowing the patient to form its own decision about the management that he's about to get. When we all become doctors, we have this ethical contrast of concepts, which is pretty much all these 5 codes of ethics. But what informed consent really tries to highlight is beneficence, whereas the physician must promote the welfare of the patient, respect of autonomy, and is letting the patient make his own decisions. And then I'm going to throw in justice as well. But justice is really mostly for research that consents and less for us. With every rule, there's always exceptions. And particularly, when are we okay to waive informed consent? One of them is a public health emergency. When the health population supersedes the health of the individual population. Best example I can give you is whenever recurring complications, whenever there's an Ebola outbreak. Then there's a medical emergency, when a procedure needs to be done immediately. Now, this institution, and I found this interesting, this institution, we do a lot of this, 2 physicians consent and whatnot, but there's nowhere in the law in which a 2-physician consent is actually required. It's really more a hospital mandate to try to avoid litigations. But I didn't know that existed. I thought always, with a 2-physician consent would be able to split from there. The next 2 is a patient waiver and therapeutic privilege. These get a little bit more on the ethical borderline. Just because a patient waiver is when the patient says, I don't want to know what's going on, you do all the decisions for me. That can really start getting into the more ethical guidelines of coercion and even malpractice. The therapeutic privilege is when the physician actually decides that the information that's going to be given to the patient is a little too emotional distraught that will incapacitate the patient to actually make a decision. Which again, then we need to form an opinion of what this is going to be an emotional distraught for the patient. And I'm quite unsure if that's something that we or I feel comfortable about doing. Finally, when the patient is incompetent, which seems for us we try to tend to do a lot. Now, competency versus capacity in itself is a huge legal argument and a huge point of debate. The biggest difference between the 2 is that competency is a legal term. However, decision-making capacity is determined by the physician. And the way it's determined is that we need to make sure that the patient can, 1, understand the problem and understand what's going on. 2, that they appreciate how this problem affects them as a person of their own. And 3, able to compare and contrast of opinions of the information that we're providing them. With that said, now let's move into models of consent. Generally speaking, these are the 3 more accepted overall arcane models of consent. The first one being the paternalistic approach. The second one is the informative approach. And the third one is the shared decision making. Now, in the paternalistic model is whenever the doctor says, you know what, this was going to be it. This is, I know what's better for you. And the physician will 100% decide the treatment without consultation with the doctor. When in Utah, now I was trying to come up with separate examples of how we can actually portray this. And again, since we're in Utah, ski would probably be the best. So paternalistic approach to me is pretty much the first day that I decided to learn how to ski. And then Dr. Bagley thought that it was the best thing for me to go to mid-gag in Snowbird. It's probably not the best choice for me, but we did it nonetheless. In terms of the formative model, is when the doctor provides information, and I did not do that to Dr. Blake. When the doctor starts providing information, and that's it. There's absolutely no other discussion in terms of what else. There's no other help from the doctor to the patient, and the patient needs to make a decision by themselves. This can easily lead to an overwhelming information. And I promise you that I spent about, 3 days trying to look at the skis that I wanted to buy just because there's way too many options out there, and I had no idea what to get. And it's mostly because our patients have not gone through the education that we've gone in several years of medical schooling. You know, when they see us, they're paying for our expertise. And I think that developed this model of shared decision making. When it's really more of a conversation between the patient and the doctor. It's the trust that needs to be built in order to actually achieve informed consent. So in the shared decision making model, we inform the patient about the medical condition. We discuss the recommendations. It is our job, and this is huge, to try to identify the patient's goal. Basically, how is it that they would like to proceed in their post-operative course? Because they vary from patient to patient. And identifying those goals and life and quality of life after an operation is really at the core of getting informed consent. Finally, this should be more of a conversation. I think this slides really summarize in terms of the patient-provider relationship and each of the roles that we just previously discussed. Now, I wish I could talk about this a little bit more, particularly in my next slide, because one of the, by talking to my co-residents, one of the best grand rounds that we discussed was this best case, worst case model and scenario of decision making. I was not able to find the grand rounds because I really wanted to rewatch it because I thought it was particularly good. And actually, what taught me how to provide informed consent in a critical and emergent scenario. This was published by Dr. Swartzy in 2013 in the Journal of Palliative Care Medicine. The basis of this model, which arises from shared decision making, and she describes this as a letter of the editor that I'm going to email you guys all, is there's a 77-year-old female with a known 7.5 abdominal aneurysm, which came to the emergency room with abdominal pain and CT findings of impending rupture and inflammation around the aneurysm. The whole point of this is how, at that moment in time, can we express what we're feeling, we express the risks of said procedure. And what she argues is that we should not give the risks and benefits as just point-blank objects, but that we should actually discuss about them in a continuum. She talks about her own discussion and how said, well, there's two options at the root of the problem. The first one is, should we do surgery? Should we not do surgery? Within each of one, then we discuss what is the best case scenario to talk about doing surgery versus what is the worst case scenario, and where are you actually most likely to lay. Same thing happens with the palliative non-surgical option. What is the best case scenario about that? What is the worst case scenario about that? And where are you most likely to do? Now, she actually encourages doing this, sitting with the patient and writing it down and have a conversation, and again, investigates what her goals of care are and what her quality after surgery is going to be, because it's the most important thing for said patient. Now that we've gone through a lot of the legal matters and definitions and history of informed consent, I want to start talking a little bit more about the meat of my talk, which is, are we doing a good job? For that, I enlisted a little bit of help. The past couple of days, I talked to all this good-looking, very competent group of individuals. I sent a survey out, and I just kind of wanted to hear about their thoughts on informed consent. I thought their answers were shocking, and I wanted to provide a little bit more literature on terms of what they thought their answers were and what the literature actually says. So the first thing that I asked them is, what are your thoughts on informed consent? I wanted to leave it as open just to hear an honest opinion, and the answers were shocking. They varied from positive all the way to very negative. First one is, it usually resorts to the intern who really isn't qualified to discuss the risks and benefits. Makes no sense. In a study from Michigan, published just last year, they actually discussed how 40% of the interns actually had to consent a person in which they actually had no idea of what the process of surgery looked like, which is a shocking number to try to be able to have a discussion with a patient about what they're about to have. The next one is, we all do it differently, which is absolutely true. And that has to be in the way of how we learn how to provide informed consent. Next one is often rushed during time constraints. And for everybody that's been in the youth team, that is absolutely true. We do a poor job assessing patients' understanding, probably because of the time constraint, probably because of the health literacy, but we quite don't know how to talk to patients sometimes. The medical jargon just comes in strong, and it's really hard to get away from the way that we talk to our colleagues, or staff with a patient, or we start with staff with a family, than having a conversation with said patient. Don't do enough to set realistic expectations for what complications look like. I thought this was particularly true, and I don't know who wrote it, kept this completely anonymous, but this person was like, yeah, we told them that the service complication of an anastomotic leak when they do a bowel section. But what is an anastomotic leak and how is it going to affect you? Because that is the part that we completely skimmed by. Is it something that we need to put a drain? Is this something that we need antibiotics? Is this something that you're going to be incapacitated for the next few months and actually have a lot of financial complications for said family? Highly variable from one provider to another. And one of them was interesting. It's conceptually the same as signing a new user agreement in ICUs. And finally, it's unfair to the patient. And I think they think it's unfair to the patient because we're not quite doing a good job. So after I sampled my residents, I really wanted to see what is it that the patients think about. So I looked at this paper that was published in 2013. From the patient's perspective, is there need to improve the quality of informed consent surgery in hospitals? Now you would think that this would be good for the patients, and we always have a conversation with patients and they exactly know what we're going to do. But some things that I found absolutely shocking was looking at people. So they surveyed 191 people, They got consecutive surveys in this hospital. If I'm not mistaken, this is from Florida. And they said, what is your understanding of what just happened here? 74% said that somebody had actually given the details of operation. 72% actually understood the potential benefits of surgery. 49% actually understood what the predictive post-operative was. And 26% had the projected recovery. I thought that was particularly shocking. There's not a disconnect now between what residents think and what the patients think, it seems like. But we all think are doing a fair job on it. So there's an inherent problem of how we're doing this. The next thing I wanted to do was talk to my colleagues and really start dissecting out what do they feel comfortable about doing, what do they not feel comfortable about doing. I'm going to get back to this a little bit later, but my question for them was, do you feel comfortable providing informed consent in bread and butter procedures, like Foley's, like Appy's, inguinal hernia? All 32 of them, because we got a great response actually, all 32 of them said, yes, no problem, I know how to do this consent. How about some more complex? I'm in surgical oncology right now, so Whipple was the very first thing that I thought about. But are we okay to consent people for Whipples with paraesophageal hernia repairs, or complex paraesophageal hernia repairs, and a esophagectomy? Just things that, we do a little bit more sustaining. The answer was a little bit more expected in terms of more in line to what I expected. People that were not comfortable was about 46% out of the 32. What I found surprising is that when I asked them if they feel comfortable providing consent on emergent, life-death type procedures, a lot of them said that it was more comfortable. It was more comfortable. People are more comfortable providing consent on emergency procedures than they were on a Whipple. Now, I understand Whipple is a very technical operation, but to me, this is what makes me the most uncomfortable. Just because the implications and the stress level and the conversation that we need to have with the patient is not just about, oh, can we get you through this surgery and this is the positive course. This is really a life and death decision. The patient that I started this conversation with, unfortunately had a clot in the SMA and had not been treated for about 2 weeks. She was transferred from an outside hospital into our system. And when she came to us, she was comfortable. She was hemodynamically stable. She had not a lot of abdominal pain. She was tender, but her CT scan showed gross pneumatosis. Something was wrong. And we knew that we were going to be opening that abdomen. Things were going to be there. How much? We don't know. But it ranged from maybe a little bit of pneumatosis and infection and ischemic bowel to what she really had, which was pretty much all of her small bowel and cecum dead. She had been feeling so well because the omentum had pretty much covered this liquefied mess in the abdomen. So she was a young 45-year-old lady, which unfortunately died that same night. And that is when I feel the most uncomfortable, just because those conversations and guiding someone through that process can be particularly hard. Now, going back to just the bread and butter procedures. I found this paper from English. It's an English study published in 2006. Now, this paper looked at about 100 patients that are underwent laparoscopic cholecystectomy, and they looked at the documentation on what the informed consent process had done for them. Now, I think that we all think that it's very easy to consent. One of the things that I liked about this paper is it actually separated the data between junior residents and senior residents. This graph represents the data for junior residents. What I think you'll find here is that the most common things in terms of bleeding, wound infection, are only mentioned less than 80% of the time. However, maybe because we're just so used to as juniors that we continue to say conversion to open was pretty much mentioned every single one of the time. And things that are important to me are things that can actually have an impact on somebody's health, such as bile leak, bile duct injury, as well as other organ injury, were seldom mentioned. So are we actually doing a good job consenting people for laparoscopic cholecystectomy? This graph was separated on the senior residents and how it is that they consented people. Now you'll see that the rate of bleeding and wound infection are much higher, and the rate of conversion to open is a little bit lower than before. I think it just counts to the experience, because I probably can count the single times in one hand that I've actually had to convert to open. However, things like other organ injury, bile duct injury, bile leak, or hematoma, those I've treated much more. And for us not to mention those possible complications of the procedure, I think we may be doing a disservice in terms of being able to consent somebody for a laparoscopic cystectomy. What about to another common general surgery procedure, an open inguinal hernia? This is a study as well from England. This is a follow-up to the laparoscopic cholecystectomy. This was done in 2009. They also looked at about 100 patients that underwent open inguinal hernia repair in the Liechtenstein manner, and they really started discussing what has been talked about. Now, unfortunately, they don't separate from senior and junior. And the good news is that we're really doing a good job talking to them about wound infection, recurrences, and bleedings. How about hematomas? How about seromas? Because I feel most of the people that actually calls us in our clinic or come back to the emergency room, we're like, this is just a seroma, it will reabsorb. And even then, how about chronic pain and nerve injury and numbness? I don't know about you guys, and I'm sure that you all know that before coming to residency, I had a surgery to remove this tumor in my brain. I cannot tell you that the only thing that bothered me was the numbness. And it took about a year to resolve. And it sucked. That was the only thing I complained about the surgery. It's the only thing that was a long-lasting effect that nobody told me about. With that said, how can we improve? No, I returned back to my residents, my colleagues, and I started asking them, how did you learn how to prevent informed consent? The vast majority of them was either done by a senior resident or a faculty member. Some people resorted to online courses, that's great. About 4 people took a class, which is great. But honestly, I've never heard about a class on informed consent. So maybe that was in medical school. Maybe, I'm not sure where it was going. There's a study in Michigan that reported that 70% of interns do their very first informed consent in the hospital within their first month of internship. Are we doing a good job in how to do informed consent? Again, vast majority is either no or I don't know because I don't know better. And lastly, do you think that an educational program about informed consent will be beneficial? And almost everybody said yes. So again, how can we improve? There's educational programs. There's multimedia, pamphlets, as well as adjuncts. There is group visits. there is 2 consent processes in the pre-op and same day. And going a little bit more into the literature about these, I first want to talk about educational programs. So the next study that I want to present is a study done in Temple University, published just last year. They realized that this was a problem within their residents. And then they started talking about, well, are we providing informed consent well? And not only that, are we documenting it well? Because that's also a huge problem. And what they did is, within the first month of internship, they developed this program in which they had one class about it, and then they had a standardized patient and an interaction with immediate feedback. Now, this was a survey that they administered after, in terms of, on a scale from 1 to 5, how comfortable are you after providing this educational experience? Now, I know that this may not be the best study, but I thought it was very revealing, particularly in these 3 areas. First one is, how confident are you that you can actually properly fill a consent and properly document a consent? How confident are you that you can probably obtain an informed consent? And all of them went from meh to, yeah, I can do it. They also asked you how effective this educational program was for you. And almost always, they thought that this was very effective, as it was the very first exposure to discussing conversations with patients. These 2 studies are very similar. Published, the first one, the one in the top was published in Oklahoma University in 2015, and the second one was at the University of Michigan in 2016. What they did is a standardized case program, a program with a standardized patient, in which there's a didactic session, and there's 3 standardized patients in which they can actually talk about bread and butter procedures, more complex procedures, as well as an emergency type of procedures, and how to navigate all these. They also, both studies actually showed that they improved the resident-patient communication, that that medical jargon usage, once they're aware of it, actually decreases significantly, as well as increases the patient's understanding of what they're about to have. Now, how about a templated course? This is also from Temple University. It was published in Annals of Medicine and Surgery. This study was a follow-up to the study that they used in terms of an educational process. And what they decided to implement now is a templated consent form in terms of outlines all the things that it needs to do. I recently heard from one of our residents that the VA is doing something like this, in which they highlight what the indication of the program, what indication of the surgery is, what is expected outcome, and pretty much guides the resident in terms of what they need to talk about. I know that this is a very busy slide, but the things that I wanted to concentrate about is benefits of the procedure. So just within the discussion of how this procedure is going to impact your life, the consented people who use the consented template pretty much 100% of the time understood what is it that they're about to get. Whereas 47% of the time in just a free handwritten report of conversation that would happen in clinic. The other thing that I wanted to highlight is the significant complications associated with growth current repair. Again, 100% of the times, you actually were able to understand what was going on or understand what was about to happen and the risks of the procedures, whereas only 30% believed that that was done on a free-handed office visit when there was just a part of the conversation. I told Dr. Volkman that I was going to give a little shout out to the bariatric clinic, because I think they actually do a particularly good job in terms of consenting patients. remember when I went this third year, and Dr. Volkman instructed me in terms of, this is how I want the consent to be done. This is what I want people to actually hear. And this is a little different from the consent that we're also used to, because it includes all the risks. And not only that, a line-to-line item of what is it that's going to happen, how is it that's going to happen, and this is the bulk of the discussion whenever somebody comes from the preoperative visit. Which is the other thing. There's a preoperative visit just for the consent form after they had gone through the whole program and got information from everybody. So this is like the ultimate step in terms of like, this is our contract with you, this is what's going to happen, and we just want to make sure that that you understand all the risk of this lifelong journey that you're going to have. And even multimedia-based programs. So I wanted to look a little bit more about that, just because pamphlets, because videos, like the breast clinic is using in terms of informing patients, I thought were particularly helpful. Now again, another busy slide, but the things that I want to highlight here is, after multimedia-based programming, after the patient was actually given videos, sorry, I forgot to mention. So the way that they did the study is they had a PowerPoint presentation and they had a video presentation in which the patient was provided. But not only that, there were some mandatory presentations and mandatory videos that the patient had to see and take a quiz after to assess their understanding in terms of just giving them the information. Now there are certain parts that they could skip, but the mandatory parts, they actually have to continue to actually go through the process. So these are the results, these are the things that I want to concentrate. Patients that were asked, what is my disease and how does it came about, was significantly higher on the people that got multimedia pamphlets as opposed to just a conversation in the office. What are the major risks of surgery? What problems can occur as a result with the surgery was also significantly higher. And what can I expect after the procedure? So, and then pretty much we can talk about all of these in terms of like other alternatives to the procedure, what happens to me in the operation, and whatnot. But I thought that was quite important in trying to develop more trust with the patient. So, in conclusion, informed consent is a complex, legal, ethical document. But it really is about trust, because the informed consent process cannot happen with the patient and doctor relationship, and the trust that we form by being able to talk to them about what they have, how we can treat it, the alternatives that we can treat, and how is it that we are going to be moving forward from now on. There's also shared decision making, which is a complex dynamic based on trust and communication. I do believe that we need to approach, that we need to improve our approach on providing informed consent. And finally, it can be done with several methods by implementing educational programs for residents. Here's where I do a little shout out to Dr. McGuire, because I know that she's also taking this very personally, and one of her QI projects is going to be advancing this and probably moving from this talk to something that we can actually apply to the residency, which I think is going to be great. And with that, say thank you.
Thank you. We have a little bit of time for questions. So I'll start with just talk about the difference between the conversation and the document signature. I love the example you gave for the bariatric program. I think that's great. And it's good the patient gets to review all that stuff. but does someone actually sit down with the patient and go through line by line how that happens, and there's a discussion? I mean, I know other people do it differently, where we have this big conversation with the patient, and then the nurse comes in and gets them to sign it. What's the difference with the discussion versus just the document?
So particularly in the bariatric clinic, this is actually something that they've been going through for the past 6 months. You know, there is a group class I didn't quite mention here, but I think the group class is actually a great way of providing informed consent, just because we give you information up front. Second, then they have a preoperative visit. They have 3 or 6 medical months of supervised weight loss, and then they actually come to the postoperative visit. As a resident, I've actually sit down and talk to them. Well, number one, the highest risk death, even though it's the lowest percentage, it can certainly happen. The second is yeast, and the biggest reason of death in bariatric patients is from yeast, and then we'll continue to go down. So I can recite all of them right now just because I've done it so much. But in bariatric clinic, I actually think it's a very line-to-line itemized and thought process in discussing those risks. The documentation is actually very important. Now, I updated some of the papers that discuss documentation because I thought I was going to go over, but unfortunately I just had a little bit of time. But that is the legal portion of things, and there's a huge disconnect in terms of what we tell the patients and we document the patients, and documentation is actually equally, and if not more important, in terms of what litigations in the future.
Felix, I would challenge that statement. It's not to avoid litigation. It becomes the subject, content of litigation. What is the informed consent? Is it the documentation? This is what Dr. Pickman is getting at. Or is it the conversation? And then my second question is, the papers that you cite are judging whether or not the documentation includes a narrative of every single complication. Mm-hmm. Is that necessary within that process of informed consent? Is it necessary within the process of informed consent? Is it necessary within the documentation? Right. So, the first question is, what is the informed consent? This is important.
I think the informed consent is both. But the most important portion of informed consent is the discussion.
Yes.
And the trust communication.
Yeah.
Absolutely.
And then in that conversation then, that one's going to cover those various things. But the papers are critical then of those written documentations that don't include a line item listing.
It's some of them. In terms of the paper that discusses if a templated consent can actually lead to understanding, that was looking at documentation afterwards in the document. However, in the other papers, such as the laparoscopic cholecystectomy and inguinal hernia, most of these were actually done post-survey in post-day one in terms of, hey, let's talk about your informed consent, let's talk about the process that you thought about it. Like, has the doctor done this? Has the doctor done that? So most of these are unfortunately subject to equal bias, but at the same time, it's one of the few ways of making sense. Sure.
That was a great job. Thank you for putting it together. I'm intrigued by this concept of therapeutic privilege because I know I use that all the time. As you've seen in clinic, talking to people about high tech. Right? I don't go into the nitty-gritty. Do they have informed consent? And we kind of talked about this too. I think I inform them enough so they have an idea. But I think if I told them every possible thing, they'd run out of the clinic screaming, right? And like we talked about, the discussion is really important because basically what they're consenting to is, Dr. Lambert, I trust you, I trust your experience, and I want you to do the surgery. And we've talked about the big things, the potential benefits, the potential risks, the most common ones. So and then you made the comment in your talk that you can't imagine having, that therapeutic, what that is, that therapeutic privilege. I would argue that you guys do that, we all do that already. So what is your thought about that? Should we be going to a model like Dr. Bosco where are we obligated to get into the weeds and outline everything and force the patient to, acknowledge that they have understanding of every possible thing? Is that possible?
Both things possible, and I think the idea of therapeutic privilege actually spans a very wide area of spectrum. I understand the example from the hybrid clinic because it's absolutely right. It's as big as surgeries you can sign up for within the hospital. But not only is there trusting and expertise, but they're also have an informed consent in terms of what their expectations should be in the hospital. And I think that that's what you do a great job in terms of even documenting that. It's like, this is how I think you're going to progress, this is how I think it's going to happen. So as long as they don't need to know the major characteristics, like we're going to go chemo, we're going to go try to get absolutely, but as long as they know what they're understanding and getting themselves into and what their respective procedure coverage is, I think it's a very good information.
So Felix, it was a good review of what I think is a really difficult topic. You touched on the things that we could do as physicians in providing informed consent. The one area you did talk about was the spectrum of patients that we interact with in the process of getting informed consent. And some people want to know the 0.0002% chance risk of having something happen, and they're sophisticated enough to process that. And there are other people, and we're supposed to provide informed consent at a 6th grade level, right?
Right.
We have people who are at a 4th grade level in their understanding of healthcare stuff. So how do you think we should approach informed consent? We've got this wide variation of patients that we see, and I don't think there's a specific one-stop solution that should be applied to everybody. And I'm interested in your comments on that.
I think it was a great comment. I think it's hard. I think it's hard because the interaction with our patients and to add to your comment, it's not just the knowledgeable level or how particular a patient wants to know about the details of their care, but then you also start adding cultural barriers, and you also start adding intelligence that we deal with somebody who's like not mentally fully passionate to actually make decisions, and I think that's just targeted. What I wanted to concentrate about was the nitty-gritty in terms of how much we should have that conversation, but the conversation should just be judged of who we have in front. Do we have a physician in front that will understand things more, or do we have somebody who we talk to at like a 4th grade level? But I don't know what the answer is. I think we'll just be tailoring and assessing each room and seeing how much information that they can get. I actually think that touches bases on what Dr. Rammer says about therapeutic privilege and trying to see how much we can judge and how much they can process. I don't know what the answer is.
Two more questions.
2 more.
Your choice.
I don't know. I think, yeah.
Felix, thank you. I think that was a really interesting and important topic, so I'm glad that you chose that. And I just wanted to make sure that the residents and the faculty know that we do have a free communications course available through the Resiliency Center. And so, the only and most important barrier as usual is time in terms of being able to do that. But it is open to residents, and it's a 1-day course. It doesn't focus specifically on the process of informed consent, but it definitely does focus on aligning your values with the patient and their family, and providing effective communication. So if anyone wants help in terms of how to do that, or also in terms of the QI project, I'd be happy to help out.
Awesome. Thank you. Dr. Nelson, I talked about the history of informed consent.
I apologize. I was I shouldn't go because it's not a question, it's a comment. And the comment is, I think the when and the who are very important. And I've had this conversation with others. Some people get their consent in clinic, which I think is a good idea in the whether you do it written on paper or whether you just discuss the procedure. So that's once. But what I would urge everybody to do is do it twice. And then
when you're on both sides of the sheet, you'll realize how important it is to see your surgeon the day of surgery, know they're there, and whether they're the one that fills it out or not, that to me is a very key element to informed consent.
Yes, and I absolutely agree. And there's actually papers that mention it. And in the sake of time, I tried to skip them. But there was a really, really, really good paper, I'm not mistaken this again, from the University of Florida, that talks about that two consent process and being able to discuss the process in clinic as well as pre-op and the day of surgery, and so to continue to try to assess for understanding.
All right, Dr. Young, thank you again. A few minutes and indications.
Yeah, faculty, can I have your attention for just a second? I've got some questions that I need to ask you for the College of Medicine and School of Medicine College Council that apparently I'm the division's representative to. So they are looking at revising the criteria for promotion to the fair process clinical track faculty. And the question is looking at, do we think that the 2 criteria of excellence and 2 criteria of efficacy is appropriate, or should we lower it to 1 area of excellence and then 3 areas of efficacy, or some variation in between? I mentioned this briefly outside of UofU here. I think, at least the comments that I've heard, is that most of us feel comfortable with 2 areas of excellence and 2 areas of efficacy. If anyone has strong opinions about this, please either bring them down or shoot me an email. Apparently I have to go to a meeting about this later on in the month and kind of give the division's opinions about the criteria, but I think having gone through the process last year, I think the criteria as they stand are pretty fair, and I don't see any need to change it. But
it might be different based on different. I mean, it's a larger discussion. Probably the decision
It's how you define this.
well, it's true, but that's not the question. That's not the question that they're asking. They're just trying to lower the. It seems like they're just trying to lower the bar because some people are. It's much more clinical and it's outside of it's hard to
If you're a clinician surgeon, you're not doing the other stuff. You can't do
If you're hired to crank out RVUs, then you can't advance.
Well, I mean, that's, what's the So those of you that have strong opinions, please send them to me an email and I'll represent the division's
What is your experience? Big party.
Okay, those who aren't here aren't interested.
You guys ready to start?
Okay.
We're gonna go with indication, guys. We had a 65-year-old male presented at UofU weeks ago. So he had right after quadrant pain for 4 days actually. No other mom. Wasn't the healthiest guy. He was a little obese, COPD, and mostly meds. He was not fibrotic, but a little tachycardia. Very close to it. No jaundice, pain, Murphy sign. He had a big scar on his belly. When he was a child, he was going down a pole or something, like a fire pole, and encountered something on the pole that drug across his belly, and he said his intestines were exposed. So he had a flat rod from ear to ear in a weird spot with his scar. But anyway, pain, hurt, quadrant, and all that. Differential diagnosis, we'll start with Molly, who shows an important to see.
Well, since he has a positive Murphy's sign, the differential diagnosis could include symptomatic cholelithitis, cholecystitis. He has a history of like a past laparotomy, so you can always think about small bowel obstruction.
Sure.
Right.
And then just bang up right at the whole right of the quadrant, that differential that can be included.
Okay, hepatitis.
Sure.
You could have pancreatitis that present that way. You could have ulcers that present that way, or GERD, but it sounds like this is more severe than reflux you've seen. He doesn't have jaundice, but you can always think about, like, if you have an obstructing mass, it could present. It's usually painless.
Sure, yeah, so gallbladder, stones,
yeah.
common bile duct, yes, something in the liver, mass, or hepatitis that we said, pancreas, and then foregut as well, for the stomach and small bowel.
Kidney.
And kidney as well. And then there's a couple of zebras, oh yeah, it could be long as you neighborhood. A couple of zebras.
Thank you. Don't know what a zebra is.
Fitzhugh Curtis is can be included on the necroleptitis. And I always think of Sean, who is not here, who likes the epinym for the vertebral appendicitis. But in any event, that's a good differential and a good place to start. So, so they got labs before we were called. He had leukocytosis. His T-billing was a scotia, and then otherwise the lab was very normal. What should we get next?
Nature.
Yep.
Okay.
How does it, could you just how does that limit differential diagnosis at this point? You say like what can be excluded or
His
mentioned?
lab, yeah. His liver enzymes look normal to me. So, well, not to me, they're just normal. So, so I would like start to like rule out obstructing the stone or cholangitis.
Okay.
But I still
Right, about the liver and hepatitis.
yeah, liver stuff. Lipase, he definitely doesn't have pancreatitis. Well,
Most likely it's
yeah.
not hepatitis.
That's about it. White count is high, so then I'm thinking something infectious.
So yeah, so we whittled this down to different, so how should we proceed?
I'd like to get imaging. I would start with a right upper quadrant ultrasound.
Yeah.
I'm looking for like fluid around the gallbladder wall thickness. See if I can see stones in the gallbladder. See if I can see the common bile duct.
So you're getting a right upper quadrant ultrasound with the diagnosis already by looking for those things.
Okay, I'll just get one. And see what happens.
Yes.
Okay.
And see what it shows.
Yeah.
So that's what I would do as well, but we got a CT scan before call, which is not unreasonable. If you're concerned about, for this guy, I think his right upper quadrant was fairly closely tender, so they were probably thinking about whether it probably could have gone with the ultrasound. But if you're thinking of something more broad or what had a broader stroke, CT scan is frequently done as well. So, Max.
We have a CT scan, what it looks like to the IV contrast. You can see an enlarged and possibly thickened wall of the gallbladder there.
For sure, thickened, yeah.
You see any stones? What do you think about that on the CT scan next?
I mean, if you don't see stones, you can think of some sort of egg calculus process.
It's a trick question.
CT scans are not exactly your best test to see stones. You can more likely to see one ultrasound.
So yeah, if it's not a CT scan, you can't trust that if you don't see stones. I think it's like 15% or 20% of them you won't see stones on this study. And then also, it's kind of hard to see on this. You can see the common bile duct right here. And I've got a couple of shots of this CT scan. On this one, the radiologist called it, and it's pretty easy to see there's a little filling defect. So I'm concerned for a filling defect in the study as well. So, and then there's a nice arrow sign as well. And so I just included this sign for this study just to talk for a second about CT scan can rule in cholecystitis, and I think this study kind of demonstrates that. This is a pretty clear evidence of dilated inflamed gallbladder. It looks like it's got cholecystitis. But a negative CT scan isn't as trustworthy as a negative ultrasound in this study. And then most of us know that the HIDA is gold standard for the highest, maybe not gold standard, but highest sensitivity and specificity for evaluating for cholecystitis. MRI is not. And then who's a slow reader? Ireland was looking at that.
Absolutely.
Reasons the HIDA might be falsely positive, just to keep in mind, you shouldn't order, or should either be suspicious of or not order a HIDA scan. People who might have poor uptake of the tracer, someone who's been NPO for a long time might have a falsely positive HIDA scan, and that big gallbladder might not fill up if it's already full of big bile. If it had a sphincterotomy, there might not be a way for their gallbladder to be able to take up that contrast as well.
And then the other thing that goes without saying is that if you've already got the diagnosis from an ultrasound, you certainly don't need a HIDA scan.
Absolutely.
Right? We see that all the time, but it's certainly not necessary.
All right, so we're calling this cholecystitis. The rest of our workup wasn't, didn't know if you did something. We weren't concerned about that based off physical exam, and also the X-ray was negative. UA was normal as well. Which would have been less than, but anyway. Cholecystitis diagnosis. What are our options? We'll go with Dr. Slattery.
So for simple acute cholecystitis, your options are cholecystectomy, percutaneous drainage, antibiotics. And then I guess if you're concerned further about any choledochal epiphysis or cholangitis, and that brings it to your CP or just intraoperative.
Let me answer the next question. That's very good. So antibiotics alone, which is most of the time, over 3/4 of the time, that will be successful in management if a patient who you don't want to take to the OR for some reason. Higher percentage for percutaneous cholecystectomy, and then of course surgery is option. And then, so you kind of already said it. So this patient has choledochal lithiasis, so we're concerned with it anyway. What should we do with this patient, do you think? You said our options were, you already said it, ERCP versus...
Yes, first intraoperative cholangiogram and common duct expiration. Right. I think it depends on your comfort level in doing that common duct expiration, because if you're expecting that the cholangiogram is going to be positive, then you have to do something about it. Otherwise, you should do ERCP first. I think reasons that you'd be unlikely to be successful with the common duct expiration would be many stones. If you're able to see that, if you have stones further upstream from the cystic duct, you would not be able to get that with the common duct expiration.
Very large.
So I'm gonna bump that up to a fourth-year resident level and ask Nick Gillespie, can you get stones out of the common hepatic duct with the common bile duct exploration?
I mean, you could scope north, I don't know.
So you mentioned that you need more information than that. We're talking laparoscopic or open?
There's the question. Can you get them out with an open common bile duct exploration?
Yes.
Yes. So just a clarification there. You can if you're doing it open. Laparoscopic is very tricky because you can't make that left turn.
You call it Alaska.
No, unless you're doing a trans polyfocal exploration, right?
Right.
That wasn't a facetious comment. It's hard to do laparoscopically, right? So if you're thinking of doing it and you're struggling, you get help. The best help you can find.
All right. So I expected, so what we did, sorry, I'm going to read that. I expected a bit more of a discussion about that in this case, since I've included the SAGES considered recommendation, including this last bullet point. So when you're faced with this possible stones and say cholecystitis, we chose to operate in this patient, just like one of the options that Dr. Slider said. We chose to operate, but some people would argue that you should do MRCP and possibly ERCP first to clear that duct. And the SAGES says essentially that both are safe. And if you routinely get MRCP, ERCP first, you're I forget their exact language, but you're getting unnecessary tests that also testing and workup and procedures that have their own risks. So if you're doing an ERCP on everyone that has stones, or potentially you're doing an MRCP on everyone that potentially has stones, you're spending a lot of money and making additional risk for the patient. So anyway,
Can you do a shout out to our training program here? I don't know if Dr. Steve is still here. We had a meeting a few years ago, and the data on the national resident experience for common bile duct exploration was presented. And the argument was that it's so infrequent, the median number was like 1, that it's so infrequent that it should be considered now an advanced HPV case, which I found actually quite entertaining, given the experience that you
just common bile duct exploration.
Yeah, given the structure here that's been put in place to support you guys on how to do it. So what we do is not what the rest of the country is doing, which is great.
Yeah, I don't know how many I've done.
Yeah.
So I give it a shot. So the next step, let's see, Dr. Tran, we went into a lap chole, and we were a little bit nervous. The guy that came for 90 hours or something like that, obese guy, and so we were very thick behind on the skin. You could see it. So Dr. Livers and I actually chatted about it beforehand. This is a tough case, but Plan A, can you just walk me through before we clip any ducts? What do we need to do? Plan A, normal cholecystectomy.
Do you want me to start with an intrahepatic or an intraoperative?
No, just before I clip any ducts. What's intraoperative?
You want to see the critical view. So
what's the critical view of safety?
cystic duct and cystic artery with, you can see the liver bit behind that, both of them.
So cystic duct and artery. So yeah, so you need to clear out the triangle and get all the fatty tissue out of the way. You need to see two and only two structures entering the gallbladder. And you need to be able to see a window behind those. You need to be able to see the hepatic plate through those structures. So those are the three components of a critical view of safety. If you're not doing that, it's only a matter of time. I took a picture like a year and a half ago and I've lost it. I had a perfect picture of what I swore was a good view, and it's a little bit more dissected. It wasn't a perfect critical view because it was hepatic plate, but I thought I could see two structures. And I was about to clip something, which was nothing, and I was about to divide the common bile duct. So it was, I too bad I lost that picture as I was showing it to everybody. But anyway, it's very easy to do if you're not getting this critical view every time, so it should be part of your practice. And this is a nice look at it where you can see the hepatic plate through this little window here. All right. The meat. So, all right. We got in. We pushed some bowel off the gallbladder. It came off nicely, but it was very thick, and it was just about a centimeter thick. The gallbladder wall was, and we just couldn't approach even the triangle whatsoever. We used the case sticker, which I always give pause during my vacations, so I don't like to call it that, to decompress the gallbladder. There you go. And it was clear white bottom, so hydropic, so lightly destructed, right? And then we weren't able to get very low at all in our dissection. So what are our options at that point? I'll ask for three. Dr. Penn.
So, I mean, overall options, I think in this case, you can start to do a top-down dissection, and get in the gallbladder and maintain your structures that way. Because the thing I'm most trying to avoid is common bile duct injury, injured bowel, getting into
top down.
Huh?
So top down.
Yeah.
That's one.
So did you say two different things there, though, Tyler? Did you say top down or get into the gallbladder?
Yeah, I did. Sorry, those are two options. I can either start with a top down, dissecting it off the liver, or I can go directly into the gallbladder and dissect it in that way. An option, always an option, is to convert to open. I don't think, it sounds like that it's not going to help me in this case, and I would stay laparoscopic.
Yep. Anything else?
Technically, you can always bail.
Bail, yeah. And one last one.
What would you do if you bailed? Yeah, if you bailed, what would you do before you got out?
I would basically do the, not a percutaneous in this case, but I would place the drain that closest to me too.
Tyler, I'm interested, you said that opening wouldn't help you.
I think based on what I'm being described here, it seems like this is not I'm unable to visualize, I don't have any bleeding that I'm not able to control. Rather, it's actually just the difficulty of dissection down at the triangle below. In that case, I don't think being open would actually help me with my exposure visualization.
I'm going to ask Dr. Nelson's going to give you a contrary view, specifically in this case. Why does open help you?
Well, I don't think you have to have uncontrolled bleeding to say, I got to open. It doesn't have to be an opening somebody up is not a sign of weakness and failure. It's a sign of good judgment. And I think you can do things open, with all due respect, that you can't do laparoscopically.
I agree. And I think specifically in this case, the hydrops is a clue that the patient probably has a stone impacted at the neck of the gallbladder and the cystic duct that you might be able to milk out with your fingers that you can't do with a laparoscopic. So I wouldn't go right to, I don't know that open is going to help us. It may still not be the choice that you make in this operation, but there are definitely some things that you can do with your hand in there in certain cases.
Alright, so we elected to not vote.
What are the other options? Because we're still missing.
Did we miss one?
Shoot a phalange there.
Sorry.
What's a partial cholecystectomy?
Oh, yeah.
Subtotal cholecystectomy.
You kind of mentioned a little bit partial or subtotal col. I think when you said get into it, I kind of thought of that.
Well, I think that's where I'd start was with those. I think at that point I would still be trying to see where my dissection planes are if I can get it off, and then bailing, opening, partial cholecystectomy would be next down on the tree.
Exactly, yeah. So can you describe just the rough steps of partial cholecystectomy? You've got lots before. Dr. Bagley.
Well, there are two types of, you said partial cholecystectomy?
So describe it.
Two types, fenestrated and reconstituted.
there are different ways to do each one of them. It's either top-down approach, and as far as you can safely, and then come across the gallbladder and divide it to open it. You can open the gallbladder from the start and dissect down as far as you can that way, or you can, on the hepatic plate, dissect off the gallbladder, depending on what it gives you and what's safest in the operation.
Yep.
And then a reconstituted versus fenestrated.
So just stick with what you said.
Let's say it's fenestrated. You take down as much as you can of the gallbladder, take the dome off and as much of the front wall as you can. Leave it completely open, leave it drained in the bed, and then coagulate the mucosa.
Yep, exactly. And then the reconstituted, the only difference is?
Reconstituted, you close the gallbladder.
Right.
So depending on how you feel comfortable with,
Piece of momentum or not? Japanese style or not?
Yes.
You guys familiar with it? It's not the rule
I don't know.
The numbers are very small, but it would suggest that if you use the omental patch, your leak rate after doing fenestrated cholecystectomy is small enough that you don't need to leak a drain if you use the patch.
I would always leave a drain.
Right, so yeah.
So if you didn't get a cholangiogram at that point, you shoot a cholangiogram after you open the gallbladder, just to make sure you don't have stones that you have to deal with.
You can attempt to. It's going to be difficult. What I would try to if I could. So yeah, exactly right. The only thing you didn't mention in those steps was retrieving stones, which I guess is kind of obvious. If there's stones you can, you should try to collect them.
Yeah, and it may not be obvious, but it's key. If you're doing a partial cholecystectomy and you leave some stones, you haven't completely solved the patient's problem.
So there's that patient we have VA, I don't know if they're still wanting us. You want to tell us about that patient and Milos?
The dude who with the one now?
The one with the retained stones.
Oh yeah. Yeah.
There's something you might have done differently.
Yeah, no, there's lots of things that were done differently. So, similar story to this gentleman.
Quickly. We're not talking about this case, so make it brief.
The only thing that, it's a good thing to bring out is when you're opening up the gallbladder as part of a fenestrating or a reconstituting, and the patient has a lot of stones. If you just open that up and you spill those stones, the patient's going to come back as this gentleman did with intra-abdominal abscesses. So using the bag during the opening of the gallbladder wall to spill all the stones into the bag to try and prevent that subsequent complication might be a good way to approach doing a subtotal cholecystectomy when you know you have stones.
Okay. And then you can either choose, even with these fenestrated, you can choose to try to close the duct, suture it shut, and then the fenestrated becomes the reconstituted when you do so shut. You absolutely should leave a drain that say either way. Depending how they fenestrated reconstituted. So this is pictures of both. The top two are pictures examples of the fenestrated, where the left side has the gallbladder stone, the hepatic plate, and the right side shows a little bit more of that hepatic plate taken off, the gallbladder taken off the hepatic plate. The bottom picture shows two examples of reconstituted where they've been sutured shut.
So what are when you're deciding to do this, and these pictures are both open because they're beautifully sutured, right? Nobody placed that person laparoscopic, I'm guessing. Maybe Rob did. So there's, when you're considering what to do, you guys went through this intraoperatively. You think about the advantages and disadvantages of a fenestrated versus a reconstituted. What's the main advantage or what's the main problem with a fenestrated?
Can you go back to that picture?
Yeah.
So
the top one is fenestrated. What's the main problem or main complication that you expect to deal with, Jasmine?
Fistula. So weak fistula formation.
So biliary fistula.
Mm-hmm. Yeah.
Right. Okay.
And reconstituted recurrence of their initial symptoms, basically acute cholecystitis again.
Okay.
I still don't get why you haven't opened
it.
Done by now. And you'd be able to get that, you could pulverize the dude in, you could get the stone out of the common duct, you could do it all. That's okay, it'll go away.
All right, you want to describe it? describe.
Well, no, go ahead. Go ahead with what you did.
So these are the rates, just one study's rates of retrospective review between penetrated and reconstituted. Vial leak was over twice for the penetrated, sort of as expected. Required reintervention is real common, and it goes over. They call it similar. It includes things like ERCPs, drains, that sort of thing. And then, but required completion for cystectomy was twice as high in people that had their gallbladder so shut. So people that had to go back was almost 10%.
So you just be explicit about the required reintervention. So a lot of these people are going to have a drain. So what are you talking about with the ERCP?
So if they have a vial leak, a lot of these people will get ERCPs for stenting and or sphincterotomy.
James, I'm going to be the foil again. How many of the required completion cholecystectomies were done laparoscopically?
I did not think that. Probably all of them.
That'd be a tough one.
And then I use the partial study for all comers for this.
I did have a question for the faculty, looking at some of those pictures and having done some of these. We talked about dissecting down to the cystic duct, but by nature of the problem that we're dealing with, is anybody routinely dissecting all the way down there where you have no idea what's going on, where it is, how close you are to the common bile duct, and then putting a stitch in that, or are you just laying everything open and widely draining it in some form or fashion if you're doing a fenestrated or doing a reconstituted? Because I've never seen anybody take that risk of doing something to the cystic remnant or cystic duct because you don't know where anything is.
Yeah, we can go around the room, but my preference would be fenestrated and not try to put the stitch in. You go down as far as you safely can. At some point, you're feeling uncomfortable about it, and that little voice in your head says stop.
I think what's nice about that elemental plug is because instead of fully reconstituting it, running it closed and having a pouch, you at least fill it with something and you open the drainage. So you don't have to get all the way down.
The safest, on a difficult cholecystectomy, the safest tissue plane is inside the gallbladder. You will always have a lumen of the gallbladder. When you have no idea what's going on outside the gallbladder, inside the gallbladder can guide you. And you once you're in the gallbladder, you have the luxury of going down and debriding everything until you see the orifice of the cystic duct to know then that you've gotten the stones out. And then the question is, what do you do? If you've got, there's a term that Steve Strasberg is developing all these terms, the critical view rates for fenestrating. I call this a transindibular approach. And if you can close the cystic duct because you can suture laparoscopically, great. If you can dissect once you're inside the gallbladder, a cone or the infundibulum down to the orifice of the cystic duct and throw an endoloop around it and trim off the rest, and you've actually completed a cholecystectomy. But the point of this is you go until you're no longer comfortable. And the old days of, this was a hard open cholecystectomy of debriding the gallbladder, cauterizing the mucosa, and leaving a drain, which is really the fenestrating, is completely acceptable. Because these leaks will heal. The leaks, if it's just a cystic duct leak, it will heal as long as it's drained. And if you don't put the omentum in it, the omentum is going to find its way to it. Fill it with something.
Question and a comment. I think for a lot of things, for typical laterally and difficult things, you convert the things easier, and then it's not easier. You actually sometimes you can't see as well because you don't have the magnification, and so I used to convert, and that's still a small path, but I used to convert a lot more often. Sometimes it doesn't make it easier, and in the case of you do a partial colon microscopically, you might do the same thing. You might do the same thing over it, but now the patient now has a large, subcostal incisions or stable infection and instability, so it's not. it doesn't always make it doesn't always make it easier. So that's just in my experience. And then the other, I guess, the question I would have is, did you find that whether cauterizing, the mucosa reduces the rate of bile leakage, demonstrating?
I was looking into that. I didn't specifically find whether it should decrease the rate, but none of the guidelines specifically called out cauterizing mucosa as well. So, yeah, I think I'll run through. This is so post-op we were not able to do a cholangiogram, so we ended up doing an MRI the next day. There's a little filling defect in the condyle left. So this was his hospital course. MRCP showed stones on post-op day 1. The GI couldn't do a BRCP, but again, normalized LFTs. No bile was coming out of his drain, and so he was really doing quite well on post-op day 2. We didn't want to make him sit for a week, lived a few miles away. So we discharged him home. Just yesterday he came and got an ERCP. There was no cystic duct leak, and we pulled his drain post-op day 9. So I needed it very well.
Nice management of complicated gallbladder.
I go on this to talk as little as possible, so I can also give you all of your
That's my goal too.
Okay, so it's about breast cancer, but we're going to pretend it's not about breast cancer at the beginning. Anybody know who this is? In 2 seconds. So we have cured the disease in its early stages, but after it's reached a larger size, no one's cured it.
Scale.
Yeah, Nelson. A good picture of early Dr. Nelson. So this is in the 2nd century AD. Nick Galen said this. I thought that was pretty impressive, right? So we cured it. Why are we still talking about it? So anyway, we'll move on to TN. So she's a 55-year-old female who presents with a right breast mass seen on screening imaging. I said screening imaging because she's a slight bit different, but we'll talk about as if she had a mammogram.
So did she have a palpable mass or a
No,
mammographic abnormality?
Mammographic abnormality. And actually, it's an ultrasound abnormality. But yes. So, sir.
She's the only intern that's been picked on.
Oh, great. Let's talk about it. So, what would you do for her? This patient comes into your office. All they have is a mammogram that shows a mass.
A mammogram or an ultrasound?
Mammogram. Let's say mammogram.
For the workup. So I would want a full history and physical.
Okay. What are you going to focus on?
A lot about their, everything. I would want to know their gyne history. I would want to know their.
Why don't you give us the top, we'll make it focused, the top risk factors for breast cancer.
What? Any family history of breast cancer.
Well, and this is stupid, I know, but being a woman, being over 40. And then family history, and then keep going.
Oh, sorry, I thought I was doing that.
There's some clues on that list.
So the top 2 are family history, are being a woman and increasing age. No. Anything else? What else did you talk about? Family history? Anything else?
As far as risk factors?
Yeah. What are the other big ones?
Appetite's coming up.
Big risk factors for breast cancer.
So parity, like how many kids they had, or if they had kids.
Yeah, what age is the first child? So age over 30 of your first child.
Don't forget to ask about prior risk.
Breast cancer. Prior biopsy. Yeah. We'll go through this for, we don't have a ton of time, we're going to focus on stuff at the end. But null parity, family history, breast cancer, genetic predisposition, which seems obvious, but race, ethnicity. So Max, which race ethnicity would be the most concern. Specifically, is there like a subgroup of Caucasian? Yeah, so Ashkenazi Jews, and then history of radiation surgery. Then there are modifiable risk factors, so OCT use, HRT use, obesity, lack of breastfeeding.
There's
And
one
then,
on there I've never seen before, shift words.
yeah, night shift is more likely to breast cancer. And then all these histological risk factors, so LCIS, as a diagnosis, atypical ductal atypical dysplasia. Okay, so let's say that this lady is a 55-year-old lady who has never had a history of breast cancer, no family history of breast cancer, has 3 children, did not breastfeed. She has she had her first child at age, I think it was 26, 27. And then she does not have a known genetic predisposition. She has taken OCPs and she does not have HRT currently.
One thing I just want to point out is that the risk factors that are being listed here, just like any cancer, oftentimes are why we structure or put people into screening programs in the first place, right? So a lot of these things are identified. There's a group of people that have certain risk factors that get higher risk, and then they get put into various screening programs. There's not many. So at this point, this isn't as useful. It is useful, but it's not as useful as what you just said, which is they've already shown up with a screening exam with a positive finding that has to be addressed. So all those things are important, but not that important at this point.
It's not that important for our treatment of the cancer itself, but the treatment this patient had will be.
Correct.
These are all under the umbrella of the Gale model, and this is for population screening to show increased risk. When someone comes to you with a palpable exam finding or an imaging abnormality or a known cancer, you don't say, I go through Gale.
Right. So these are all, again, population risk or population epidemiologic data for who should be at higher screening or different screening models, or who should get additional interventions to mitigate the risk of breast cancer. So I say that only because, again, this is the person with palpable breast cancer who is fit. This person comes in with this screening mammogram. This is right and left cranial column, and this is MLO. I'll tell you, this doesn't really give me any information. She's got super dense breasts, which is what I can see on this. And they actually did not detect this mammographically. She had such dense breasts that they were ultrasounding per yearly in California.
Now let's make sure we say in California. I don't know. Kirsten, do you consider ultrasound a screening test?
So there are studies that are ongoing to standardize ultrasounds. You place the breast in a bath of water, and there's an automated ultrasound that scans the entire breast. And at USC, we were ordering whole breast ultrasounds, but you have to understand that that is extraordinarily time-consuming for the breast imager. And it's very dependent on the person who's doing the ultrasound. So if that's not the breast radiologist and it's a tech, your imaging is only as good as what's imaged. So I would not say that is anything that we should ever mention.
It's very user dependent, and all the things you said. So we haven't used it as a screening.
Is there something we do differently than ultrasound for either high risk screening or for dense breast? Yeah.
Okay. Well, you can do MRI.
So I'd say that's a more gold standard in terms of screening.
For women who are at over a 20% lifetime risk of breast cancer, adding an MRI is absolutely what you should do.
I think of it similarly to indirect ultrasound, which is MRI. It's also standardized, and you can look at them across different providers as opposed to having just one person interpret it, which is user dependent.
It's different. Focus exam and focus on screening in this country.
All right, so she had an ultrasound let's say next year an ultrasound biopsy, there were 2 masses in the right breast, and there were biopsy proven as the nasal ductal carcinoma, grade 1, ER positive, PR positive, HER2 negative. There was biopsy also with the focus of DCIS. So that was 1 mass, and the other one showed dense fibrous tissue that was acellular.
So Lauren, she says, oh, great, I have stage 1 breast cancer. I'm going to be okay because I have stage 1. What's the difference between grade and stage? You've heard this too many times.
Well, grade is what it looks like histologically, so how aggressive the cells are, whereas staging, she needs to further work up. We have no evidence of her staging.
Grade is based on 3 criteria.
I think it's like atypia, necrosis, or mitoses.
Mitoses, nuclei, and nuclei.
Yeah. And stage is?
Tumor, nodal status.
Size and nodal status.
Remember, when you're looking at this grade, or the biopsy, that's like saying I have on a brown outfit. I'm just wearing a brown coat. We have one teeny tiny little part.
Andrea, what do you think about her nodal status, or not nodal status, what do you think about her receptor status and her grade and her prognosis? Well, that is a 1.5 centimeters.
Yeah, so I mean, she's ER/PR positive, HER2 negative, which is the best prognostic. And in terms of the hormonal status, it's the best prognostically, I guess. So she should be sensitive to hormonal therapy for those receptors. She's grade 1, which is the least aggressive, so also good prognosis. Yeah, what else do you guys?
So just, I'll ask you also, HER2, what does it stand for? Yeah. Right.
Yeah, Herceptin. Yeah, Herceptin.
Herceptin stands for.
Right, but.
What's her H?
Human.
So it's a tyrosine kinase receptor. Yeah. So it's a human abnormal receptor.
That was perfect.
It's also, you'll see new, so Lauren, what new is, or B, or any of this?
No.
Gene, protein, or B, and here is what we can use.
So, not all breast cancer is the same, right? There are patterns. This is ER positive, PR positive, HER2 negative, low grade, that's all good. What if it was triple negative, high grade? What are the, I can't think of the right way to ask you the terms that define those things. You've heard of basal types of breast cancer versus luminal? Anybody know basal? Is that on board? Is that right? Okay, forget it.
There are 6 subtypes there. Yes.
Subtypes, right. But they occur in patterns, and somebody over there said this is a good pattern. And it's a good pattern because it's low grade and there's a lot of treatment options. Although it's a little funny.
I'm going to ask a question that Dr. Nelson asked all of his patients. Do we have enough information? So we have this person, we have a diagnosis, we have a ultrasound that says it's a 1.5 centimeter tumor. She's a T1C and 0 stage 1A. So do we just stop here and go to the operating room, say trans?
No.
All right, what do we need next? Or what else do we need? This is a little bit of nuance of this.
So N0, we did a clinical exam and you don't feel any clinical.
Yeah, so she's clinically N0.
Informed consent.
Informed consent. So do we need anything else before we diagnose?
So what you're asking, I'm assuming, is, or what is your proposed treatment plan for this? And what information do we need to actually proceed with that treatment plan? Because the treatment plan hasn't been proposed. I haven't heard it.
No, so let's say there's no treatment plan yet. Do we have enough information to make a treatment plan, or do we need more information before we make a treatment?
We have enough information.
Stokes, is she ready for the OR?
I would get an ultrasound of the axilla.
And?
Potentially an MRI.
Good.
Why would you get the MRI?
She's a young patient and see assess for contralateral disease.
Yeah, and she's also got what?
She's got very dense breast tissue, and you can't really assess it on a diagnostic mammography.
True, and there was something about a biopsy that she had as well. Anybody catch it?
She has DCIS.
Yeah.
I think with this, so she's got a mammographically occult cancer, and DCIS, either of those two. So.
I mean, I would not say, we don't know. I mean, it's kind of, you can offer her.
Right. That's why I said.
MRI is not going to help diagnose DCIS, and it's not indicated just because she has dense breast.
We had this exact discussion on CSAT, and the answer was MRI.
I think this is controversial. We used to say MRI, never, it was too expensive, insurance didn't cover it, on. For me, in my practice, I want to know, does she have anything else in that breast? Does she have anything in the opposite breast? I know it's too sensitive, I know there's a lot of false positives, but I get it.
I'm mainly playing devil's advocate. I mean, would I do it? Yeah, I would do it. I pulled that trigger for much less. But I mean, is that something that, I guess if you're saying it's on CSAT, then it is testable, but I would say we don't have consensus guidelines on that, and you would definitely get pushback at some institutions.
But
exactly.
So maybe the point would be, why are you getting the MRI, and understanding what that is, so if you're in an oral board situation, because this will be a question that people will get. Why are you getting additional studies, whether it's an ultrasound or an MRI? What are you thinking about, and what are you hoping to get from that? And it sounds like evaluation of the contralateral breast or other potential primary breasts that were breast cancers that were missed in the ipsilateral breast, and then potentially for DCIS or margin assessment?
My 3 for her is, or at least 2. So she had another mass that's seen on ultrasound. Biopsy didn't have cells in it, so are we going to have to do more extensive surgery? So she could get by with a single lumpectomy versus doing a mastectomy, or a 2 lumpectomies in the same operation. Do we need additional biopsy? That other one is a substantial error, or discordant, essentially. And then to extend the DCIS, again, for the same purposes, based on the fact that we can't see her DCIS on her mammogram, would be my 2 reasons.
An MRI is not going to show you whether that other mass though is discordant. That's a discussion that you have with radiology.
But yeah, that's my thought. So the other thing that this lady,
What about the ultrasound that was said? You definitely have to get the axillary ultrasound. I mean, I know she's like, in a hypothetical situation, she's getting all these whole breast ultrasounds, but would you have to get axillary ultrasound?
Have to.
I just wanted to clarify that.
Have to versus choose to. Yeah.
But it wouldn't be wrong not to.
Correct.
We have an institutional.
If we were to say on the
but yes, I would not. I wouldn't bring up that we get an ultrasound. Just potentially easier though, so I would be.
I think it would be safe on oral boards if they said, if the axillary ultrasound came up, if you work very closely with a very good mammographer, which we have here, and they're used to doing it, and they're blah, 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 because you do get some good information. What if she got an axillary ultrasound, which she did, and it showed a great big node, which it didn't. But if it did, and you did a core biopsy, and you came back with a node positive disease. It's the same rationale for doing the MRI. What if the MRI says there are spots all over the breast? What if the axillary ultrasound says there's a positive node? You're getting information in advance of surgery, so to guide you in the treatment work.
Let's say Pender. Yes, sir. Who needs Pender? Who needs a genetic evaluation?
People that score high enough on the Gale model. People that, so classically genetic evaluation would be if there's 3, 2, 1, I believe that's this rule, so if there's more than one of that.
A lot of information that says that more than a few are what your cancer is.
They're young, if there's multiple family members, or other high risk factors like some of the other ones here listed.
Look at us in the development times that there's a great, an entire NCCN guideline article on who should get genetic testing.
I mentioned this in my lecture to you guys. This
that's my next one, is that this consensus statement says that, so those are who you should recommend it to, that's, the burden is on you. And this is, if the patient wants it, they should take it, essentially. And that's a consensus guideline from the Society of Surgery. So, this is another, Dr. Nelson is the batting order, are we going first in this patient? And for time, because I want to talk about the operation as well. Yes, we're going first in the operation.
Yeah, I think this case, we go first. We batting first, assume the ultrasound's okay in her arm and there's nothing else on her. But what are the goals of surgery, Dubetsky, for breast cancer? You're going to tell her, go back to informed consent, sit down with this lady and say, here are the goals of surgery. Basically, 2 in breast cancer.
Yeah, so in breast cancer, my goals of surgery are an R0 resection, so remove the cancer.
Get
That
rid of
with
the
margins
cancer.
if it's DCIS, that means I need margins if it's cancer, it's no tumor on ink, and I want appropriate nodal staging.
And stage, right? Get rid of it and stage it. You'll do that with 2 different operations, right? Which are?
So you're either going to do a mastectomy or minimally or breast conserving therapy or lumpectomy, and you'll do that also with a sentinel lymph node biopsy, or in some cases, depending on the stage of the cancer, nodal status, you'll do an axillary lymphadenectomy.
So I haven't heard Dr. Madsen speak up, so she's not here. But this is where the whole decision-making thing comes in.
So, Sliker is this version. Yeah. So Halstead, I think, is interesting because he talked about the nodal status, even way before genetics, and we had more scientific data. So, but there was actually a predecessor of this, it was C.M. Moore, who first presented that everybody who gets a mastectomy should get axillary dissection, even in 1877. So radical mastectomy, we're not going to talk about. Cancer operation, lumpectomy versus mastectomy. So this patient is a different piece necessarily, but so she had 2 foci on the MRI. We're likely going to end up doing a mastectomy for her, if not doing a very large lumpectomy. But I want to talk about, so we did a bilateral mastectomy, a right sentinel lymph node biopsy, bilateral direct implant reconstruction, which actually in the middle of the operation switched, so she was consented for a direct implant, and then we ended up putting tissue expander in. So this is the most interesting part, right? So she had a sentinel lymph node biopsy with 1 of 4 nodes with micrometastasis, approximately 1.1 centimeter. So I say, Jess, what are you gonna do intraoperatively? So we sent these from frozen. We got 4 sentinel lymph nodes.
Yeah, I was going to take a step back. We sent these frozen. That's another real clear area, right?
Yes. All this is unclear, sorry.
Well, if you can justify what you're doing, I guess it makes it better. But if we send it for frozen, you get back the report, there's a micromet in 1 of 4. And then you got an intraoperative decision, right? So what's this?
So the intraoperative decision is whether to proceed with an axillary dissection.
Right. Now remember, she's getting a mastectomy, not a lumpectomy.
Yeah.
So can I can't, maybe these guys can, give you literature or studies that support not doing, scientifically support not doing an axillary dissection?
So with micromets, I believe that she would get postoperative radiation, and so I don't think it's necessary to do an axillary dissection.
We didn't either, but I'm not sure that you can apply the Z11 criteria. Now there's the AMROS, there's a billion different trials and things, and these guys will all correct me, but this was a game day decision, intraoperative, to say, yeah, it's a micromet, the likelihood of more disease further up, she's probably going to get, is she going to get radiation?
Yeah, that's a good question.
Yeah.
That's a TBD.
Yeah, because our radiation guys give it to basically everybody.
She had a whole lot of really interesting intraoperative decision making, and I actually was perplexed. So I got the call, and Dr. Nelson was in the room, and was like, "I'm going to classes, might need to hold up because we might be doing an access section." And I called him, and he said, "Sounds good. Have him proceed." But I mean, I don't think it's clear. Right? This is one of those where the AMRO trial that Dr. Nelson mentioned is a trial that puts axillary radiation versus axillary lymph node dissection. The only problem is it was all comers, so there were lumpectomies, mastectomies. Actually, the majority of them had very small cancers with lumpectomies. So it also wasn't powered for making that decision. So even though they didn't show a difference, it was a non-inferiority study. So it wasn't powered to show whether or not one was better than the other necessarily. And the only thing that it did show is that there was less lymphedema with axillary radiation or with a axillary lymph node dissection. So the recurrence rate was similar. Recurrence in the radiation was about 1.2% and 0.4 to 0.5 in the axillary dissection group. But again, not powered for instances of that.
Was the potential for radiation what switched plastics after? I'm just curious what their decision.
There's a whole lot of things. She had super thin flaps, and her breast tissue was densely adherent to her subcutaneous tissue. I'm talking about millimeters. So there's that, and on top of the fact that we did discuss that she might get postoperative radiation.
And that's frequently very common. They consent for both, and then sometimes they do SPY to look at the perfusion of the flaps. And they're also here, I would say, more conservative in placing tissue expanders rather than doing direct to implant. That is a trend that we're seeing people move more towards doing direct to implant because patients like it.
Kevin's being kind too. There was also a little matter of a buttonhole that I made. I think this was her surgery mimicked her mammogram. Remember that big white dense thing? Well, it was very adherent, and that sounds like an excuse for my making a buttonhole. But it was a hard. These were nasty flaps, and I think they did the right thing by not putting in the implant right away.
So she got a bilateral mastectomy. Anybody? So say, Liz, why? What are the indications for bilateral mastectomy or for contralateral prophylactic mastectomy?
So if they're positive, that's necessarily an indication you'd have more concern.
It's kind of a trick question, right? It's all about risk reduction. So what is the risk reduction with contralateral prophylactic mastectomy? So 90%. But that's a relative risk reduction, right? So we're not talking about an absolute risk reduction of 90%. So if you're, let's say this person who has breast cancer is going to have a 0.5% chance per year of developing breast cancer over the rest of her life, right? And you're reducing that by 90%. So your absolute risk reduction is pretty small, right? Whereas opposed, you have somebody with BRC positive who has a 90% chance of developing it in the other breast, up to 90%. Then your absolute risk reduction is going to be 80%. Make sense? So really, this is all about your absolute risk reduction and a conversation with the patient, because this patient's adamant about it. We weren't going to change their mind, despite what we did. But I do think the most important part of this is what is their actual risk and how much risk reduction are you doing? Please.
Once you go above age 50, really your risk, because you see those mutations, those presented at a younger age, so your risk reduction.
And for the axillary discussion, the risk of axillary recurrence is very well combined with what we do in axillary dissection, in this case, she may not be there.
All these are recorded for your appetite, so that's what I'm going to talk about. There you go.
So you don't feel like on an oral board situation it would be acceptable to admit radiation, to admit an axillary dissection in that situation? Even though it's mastectomy?
This is a micromet. There are kind of two conversations here. I would not, on your written boards, think that you can extend Z11 criteria to someone getting a mastectomy. No. For your oral boards, you have more leeway, and as long as you are able to articulate, and I would say, understanding that this patient is not a Z11 candidate, at our institute, or in my practice, I would, you just have to be able to articulate your thought process.
thought process needs to be rational.
What I